Now let's go on with question time. The first three speakers will focus on one of the critical points addressed by Jamie, and is the acquiring data for feedback. Let's start with Eva Pagano, Dottoressa Eva Pagano. Please, Eva, on behalf of Turin, Piedmont region, who are involved in oncological care. Please, Eva, you can start your speech. Please.
Okay. Thank you, Nera. Hello to everybody. Hello, Jamie. I'm Eva Pagano. I'm the CoPI of the VP3 of the A&F project. That is the working group involved in audit projects in oncological care in the region of Piedmont. We are applying different methodological approaches of audit and feedback to provide a quality improvement in cancer care at regional level. And we are adopting different methodological approaches, mainly characterized by a different degree of utilization of ad hoc data rather than readily available data. We have one randomized clinical trial using the audit and feedback strategy to support the implementation of the ERAS approach, enhanced recovery after surgery approach, within the network of regional hospital for colorectal cancer surgery and hysterectomy. In this project, the data collection is performed by the centers on a web-based database, but are strongly supported by data managers in the data entry, quality of data control. Then we have a study on ovarian cancer where the data collection is completely carried out by the centers, and our central role is only in quality of control of the quality of the data. And now we are planning another audit for bladder cancer, where we are planning to make use of more administrative data, asking the center only to provide a minor amount of information, for example, the pathology data. We believe that one of the key aspects in audit and feedback is to have timely and credible data about the relevant aspect of the healthcare process and the outcomes. But the audit and feedback based on routinely available data is generally a shortage of clinical information, and is limited in assessing the appropriateness of care and does not allow for a proper risk adjustment. On the other side, the audit and feedback based on ad hoc system like dedicated web-based database needs for specific competencies, resources completely available for that, that are rarely available outside a specific project like the EasyNet. Up to now, in our limited experience, in both the cases, both using ad hoc data rather than really available ones, we are experimenting a high delay between the period of observation, the moment of data collection, and then the final feedback, because every step needs a lot of time and effort. And we find hard to counterbalance the timeliness of data for feedback with the informativeness, all at reasonable cost. And we are a bit skeptical on the possibility of adopting such approach in real life, where you don't have specific resources to support this kind of activity. So our question is, if you think that the literature could help us in providing evidence on the choice of the best method for acquiring data in audit and feedback, and which is your direct experience on this. Thank you.
Yeah, thanks very much. A fantastic question, and I'll dance around it for a while. I mean, I think the answer to the notion of is there clear literature to support this, I think the answer there is no. I think it's fairly clear that we are in sort of uncharted territory because of the access to data that we are all sort of wrapping our heads around now, and that there is clearly that problem is only going to get bigger, in the sense that there's going to be more data available, and how do we deal with it in a sustainable and reasonably quick way. Even now, of course, though, it's you can audit way more than you can provide feedback on, and the issue of whether you're going to go for really good data or data that's readily available is something that is I think everybody is wrestling with. We are doing a little bit of work to try to figure out answer a sort of related problem, which is how do we know, can we determine beforehand that something is a better bet than another? Focusing on this kind of data is a better bet than that kind of data. So we're doing some work in the test ordering field, for example, and we've just done a scoping review to try to figure out when people decide to do an intervention, decide to develop an intervention to reduce test ordering or improve test utilization, what are the factors they consider? What are the things they think about in terms of focusing on here versus over here? And the thing that's come out of the the scoping review of anything is that there is a lot of potential things to consider. It's not just cost, frequency of the test, but it's also, whether tests are bundled, whether there's implications of false positives and downstream effects of testing, and all those kinds of things. There's an enormous range of things to consider. And so just trying to figure out how to make those choices is definitely a challenge. So I feel your pain. I think one thing that we can clearly say from the literature is that we have to avoid the inclination just to present the data that we have, right? Just to take the data that we have worked very hard to generate and compile and clean up and all of that kind of thing, and presenting and thinking that's the end, your job is done, right? Instead, once you've done all that work, to figure out, to carefully choose what you're going to present to whom. It sounds like you guys are wrestling with that challenge, but it's very often people are, they've done all this work to develop a dashboard, and so we're going to present the dashboard to people, let them figure out what's interesting and what's actionable, rather than doing that work up front. So I think that's one thing we can clearly say. We know that there are lots of indicators that, whether it's admin level indicators or bespoke generated indicators, that when you create the data and present it to someone, that very often it's not clear to the recipient what they're supposed to do about that. So we had a meeting recently. We're talking about test ordering. One of our members had done a lot of work to generate model feedback on ordering ionized calcium testing in critical care. And so it was clear that there was variability between individuals, but there weren't any clear guidances on what are the circumstances where calcium testing is inappropriate, right? How do I know, if I'm high user of calcium, that that I should do something different? So there is a real step to make between choosing your indicators and choosing the ones that it's clear that what they need to do. So that might come from admin data, that might come from bespoke generated data, but it's not necessarily clear that one of them is better than the other at producing those actionable kinds of things. in terms of, you know, strictly sort of admin versus generate your own data. I mean, admin data are clearly more sustainable. There's a fire hose of admin data. Ad hoc data is often less so. Admin data is less precise. Ad hoc can be more precise. I think the best I can say really is when you're to pilot the displays, to pilot test them, whatever indicators you have available to pilot test them, and elicit from the recipient which outcomes feel actionable, which ones do they, and the action isn't always necessarily there is a clear guidance that this is inappropriate and don't do it. Actionable might just be, this is really interesting and gets me thinking and gets me discussing with my colleagues, right? And so that's a situation where you might have an indicator, whether it's admin or not, that is interesting and gets people talking, and without any sort of clear guidance that this is inappropriate, right? And so, I mean, that's I know it's a long-winded answer, but the notion, I think, is that regardless of whether it's admin data or bespoke data, pilot it and try to figure out which ones people find actionable. And that's I think the closest I can get to any sort of guidance from the literature.
Thank you.
Thank you.
Thank you, Jamie. And now on with the Regione Calabria, Professor Costantino Di Carlo. I invite Costantino to speak. The issue is similar to the previous one on one hand, acquiring data. And I know that Costantino has 3 questions. I like to ask Costantino to ask the first 2. The first is similar to the previous one, but in another context, Jamie. And I ask Costantino to leave the third because it's more general. We'll ask at the end of the meeting if we have time. Ok, Costantino? Quindi le prime 2 possibilmente, così guadagniamo un po' tempo. Grazie.
Okay, Nera, thank you very much. And good afternoon to everybody. I am Costantino Di Carlo and I am a gynecologist. And as a gynecologist, I am quite naive when it comes to the field of audit and feedback. Nevertheless, I am the PI, the principal investigator for WP6, which deals with the efficacy of an audit and feedback approach to reduce the cesarean section rate in Regione Calabria. Regione Calabria is the southernmost part of Italy, the tip of the toe, if you compare Italy to a boot. And the first question is, we mainly gather the data from administrative files, such as the birth certificates and the hospital discharge forms. But these data are not collected for research purposes. Therefore, the quality of the information included is quite low. They are often hastily written down by a tired midwife in the delivery room. So the alternative approach could have been to have a bespoke, customized file that each obstetric ward should have filled by their own. But we felt that this approach would lead to a very low compliance. So the first question is, which of the 2 approaches would you favor in our case? The second question is related to the particular condition that we are living today with the COVID-19 pandemic. Of course, all the training and management will have to be done by remote. Do you think that this will negatively affect our project? And do you have any suggestion for us? Thank you.
Thanks. Yeah, thanks very much. Again, the issue of, quality of data and access to data is going to be a recurring theme for anybody who does this work, I think. Certainly, the issue in terms of helping people design and use bespoke data collection instruments and generating a sort of practice pattern that will increase the development of good quality data is its own intervention, right? It's a challenge on its own, and it can be the sort of focus of lots of different intervention strategies to try to educate people about why it's important, to try to make it easier for them by providing tools, and also providing potentially feedback in order to encourage people to do it. All of that sort of thing can be, you could think of trying to get people to generate better ideas, better data as an idea for an intervention in its own right. But in terms of, as it stands, as you say, the sort of bespoke approach is going to have sort of low compliance and low sustainability probably. So from my point of view, again, it sort of works back to this notion of can you provide indicators wherever they come from, whether it's sort of admin data, low quality compared with sporadic, good quality data. Can you generate a message that's actionable for the recipient? So, you know, maybe based on the admin data, all you can say is, you know, your C-section rates are high compared to other practitioners, something like that, and nothing else, right? That in its own is, you know, not terribly informative, because there'll be some physicians who they have high rates because that's what they do, and, you know, all of those kinds of things. They have different practices. But simply having that high-level data and pairing it with recommendations like, in this circumstance, C-section is not indicated. In this other circumstance, C-section is. Then that can start a discussion. That can start, you know, it's clear that the data don't support the strong conclusion that, you know, you're doing C-sections in the wrong circumstances, but relatively high level, I guess, low fidelity data plus clear recommendations can still start a conversation. And I think that's where you start to focus your decisions, is based on do I put effort into getting people to give me better data, or do I just use the relatively low quality admin data? It's about whether you can come up with messages that elicit these kinds of discussions, right? In any case, I think we're always going to start with data that are not ideal, and this sort of trade-off between good quality and clear sustainability is going to be a challenge. And I think it's the messaging that we can generate from it that's the important part. In terms of the other question around you know, COVID and using distance techniques to train and that sort of thing, I don't think we really know whether online training needs to be less effective than in-person training. I think you know, we're still in a situation in the feedback literature where the standard has always been, let's generate some data and email it to people, right? And to the extent that we can go further with the social construction and have a facilitator on a Zoom call, or have a number of your colleagues discussing their feedback separately, that can all be done online as well as in person. So I'm not, and indeed, you know, there's potential trade-offs, like you may be more likely to get people on a Zoom call than you could get them in an actual room, right? And so I think that the issue is how you frame how you organize the session to encourage discussion and construction of the feedback, rather than whether it's in person or online. I don't think we know whether one is less effective than the other, but my guess is it can be overcome fairly quickly.
Thank you. Thank you, Jamie. Then I pass the microphone to Rossella Ciurleo from Messina, Sicily, South Italy. And I kindly ask to Rossella to ask the first question. The second one's very interesting. I invite you later. So only the first question, please, Rossella.
Okay. Hi to everyone. Hi, Jamie. Thank you for your presentation. I'm Rossella Ciurleo from MIX, Centro Neurolesi Bonino Pulei of Messina, and I'm CoPI of the work package 7 of the EasyNet project. The aim of our work package is to provide a new model of audit in managing of the cardio cerebrovascular disease. We designed a proposed study with a control group, and we planned to select a cluster of hospitals provided by emergency and rehabilitation unit, plus in the 3 main Sicilian cities, Palermo, Catania, and Messina. We will subdivide these hospitals into groups according to the same criteria. The experimental group will undergo a new model of audit based on the telemedicine intervention, which has been opportunely defined with the collaboration of the skilled psychologists. On the contrary, the control group will be undergoing an intervention because at the moment the COVID-19 pandemic does not allow us to perform a traditional audit. Nowadays, different national and regional benchmarks to measure the change due to how the feedback intervention exists, but only in emergency setting, while suitable indicator rehabilitation setting are not defined yet. This is our main critical issue. My question is, in absence of benchmark rehabilitation setting, how could we define suitable indicators to detect the behavior change? Thank you.
Yeah, thanks for that. Yeah, I mean, there's certainly tons of examples of feedback where you compare change over time on its own, or compare individual to an average, those kinds of things. So certainly those are still options, even if there's no clear right answer in terms of the benchmarks. And so again, it's about sort of ways in which you can start a discussion. We have a group here in Ottawa. Andrew Seeley is a thoracic surgeon, and they have an audit and feedback group where it's a small group. It's maybe 8 or 10 thoracic surgeons that get together once a month or once every couple of months. They identify a particular indicator that they're interested in trying to improve, like an anastomotic leak when they're doing lung transections, surgery, very specific surgery outcomes, bad outcomes. And what they do is there's no clear guidance on what the best way to do that particular technique is to avoid that bad outcome. There's no benchmarks at all. And so what they do is they collect data for each of the individual providers, and they have a discussion amongst themselves where each one gets their data and starts to discuss it. And importantly, if there is someone who seems to be performing better, that they're showing showing reduced bad outcomes, those kinds of things, they de-anonymize that person. So it's a positive deviance approach. The idea is that this person seems to have better outcomes on that particular outcome, and that will facilitate a discussion about what they might be doing differently, what they might be doing that the other surgeons might be able to make use of, right? So that's a situation where there's no clear correct answer. There's no clear guidance in terms of what situations you should be doing a particular surgical technique, but it facilitates a discussion. There is simply having a difference between feedback recipients facilitates a discussion. And so what he's done, and essentially at the end of those sessions, people make a decision about what they might want to change based on the discussion they've had. And then they go back and find out later whether that's had any effects on the overall outcome. So a positive deviance approach is one example of a way in which you can facilitate an important discussion simply on the basis of variability between the feedback recipients, and potentially sort of bootstrap ways forward and improvements.
Thank you, Jeremy. And thank you, Rossella. Thank you very much. The other questions, if we have time, Rossella will ask Jamie later. Thank you.
Okay.
And now, grazie. And now another critical and important point about the feedback display and report, Jamie, comes from il Friuli Venezia Giulia, Sabrina Licata, dottoressa Sabrina Licata from Udine. And she will ask about this critical point and from their experience. Prego, Sabrina.
Thank you. Good day, all. I'm Sabrina Licata. I'm a pharmacologist, but our group is a group of epidemiologists. We focused our attention on emergency care with particular regard to 3 time-dependent conditions that are myocardial infarction, stroke, and major traumas. We focused our attention on 61 key performance indicators that we chose with the help of an interdisciplinary group. We already wrote a report about data of 2018 year. And we sent it via email to not only to emergency staff, but also to neurologists, cardiologists, and all the actors that have to take care of the patient, of the patients involved in this particular syndrome and pathologies. As a result, we noticed that each specialist focused their attention on only to specific indicators that are limited to their discipline. And now my question is that we are going to introduce them the second report about data from the 2019. We ask you, are there any suggestions about how to involve them in the whole picture of the emergency system? Because we truly believe about the suggestion, the 50th suggestions of your presentation, that is the interaction between all the actors of the care involved in the care of these patients. Thank you.
Yeah, thanks for that. Yeah, really interesting. It was interesting you mentioned that the original set of 60 indicators was developed by an interdisciplinary group, and I could well imagine how that discussion goes, where, you know, one group generates, you know, 5 or 10 indicators they're interested in, the next group does the same thing, and then you end up with a large list of things, right? I think I think there's probably some room to be done to think about the different groups of feedback recipients and what you would like them specifically to do in terms of sort of pruning down the number of indicators that any particular subgroup gets. So it's very difficult. I mean, if there is a universal law in implementation science, it's hard to get physicians to be interested in something they're not interested in, right? And so if your goal, if you start from the goal of saying these indicators are good for you, you should pay attention to all of them, then that's not going to get you very far. I think there are likely some indicators, as you say, that an individual group of neurologists or whatever other groups, cardiologists, are going to be particularly interested in because they see that as relevant to their individual practice. There's probably another set of variables that might be more of interest to the department head, the person who is involved in and has different levers, different modes of action than the individual provider does, right? Or maybe it's the people who are on a particular committee, you know, where the cardiologist and the neurologist talk to each other. Maybe they're interested in slightly different indicators. And so, yeah, I mean, I would imagine that if I couldn't imagine coming up with a feedback display that has 60 indicators that people would pay attention to all of them. I think that's just too much. But I think if you could figure out either through pilot testing or just through discussions with the different subgroups, which indicators are relevant to individual practitioners in neurology, which indicators are relevant to individual practitioners in cardiology, which ones are relevant to both but probably should be targeted to either department heads or people with administrative roles. They're also clinicians, but they also have roles and important opportunities to talk across departments and those kinds of things. So that's, I think, what I would suggest is sort of slicing up your recipient groups in more detail and trying to target those specific groups with smaller numbers of indicators.
Thank you so much.
Thank you, Jeremy. Sabrina, as for the others one, the second, eventually in the last part of the meeting. Then I pass the microphone to Giulio Marchesini from Emilia-Romagna. They are involved in the chronic care implementation of the feedback in chronicity. So I kindly ask Giulio Marchesini to ask only one of the two questions you prepared. Perhaps the second one is better if you agree.
Yes, perfect, Nerina. My name is Giulio Marchesini. I am the PI of the work package number 4, Regione Emilia-Romagna. And we are engaged in refining the audit and feedback into very common conditions that are diabetes and cardiac failure. And I have two conditions where we have a lot of data, administrative data, and mainly administrative data. And there are a lot of attempts to refine the audit and feedback by adding any sort of new data that might be collected. For this reason, we started our job by making some focus groups with patients and with also the health personnel, that is nurses and physicians, in order to verify if we had any unmet need in terms of the possibility to implement our audit and feedback. And my question, I come directly to the question is that we have a lot of possibility to implement our audit and feedback by adding data from patients, that is the use of patient-reported outcomes in audit and feedback, and as well as the possibility to implement, at least in some areas of our regions, the classical data that are used for audit and feedback, that are mainly administrative data, by a lot of clinical data, and this is commonly done in audit and feedback, but also social and economic data of our patients, because we have the possibility to, through the data that have been acquired by the epidemiology service of the metropolitan area of Bologna, also to include this sort of data in the analysis of the needs of our patient. How much these data may really help in refining the audit and feedbacks?
Yeah, and thanks for that. A really interesting question, and it's something that's fairly new to me in terms of trying to incorporate that level of data into what are typically challenges, typically tasks that are very specific in terms of audit and feedback is often targeted specifically to a particular practice. It sounds like the feedback you're providing is a little more general and a little more involves a wider range of potential behaviors for the practitioner. I think there's, in terms of mechanisms of feedback, I mean, one of the clear benefits of feedback is to garner attention, right? So simply adding additional socioeconomic information and showing how maybe behavior or outcomes differ based on socioeconomic data has the potential to bring attention to that issue from the feedback recipients who might not be spending much time at it, much time thinking about it. So I think there's potentially a benefit there. It almost doesn't matter quite the socioeconomic data you provide, really. It's more sort of bringing the general issues of inequity to the table and helping people discuss it, right? So the specific outcomes may matter less rather than the general lesson about inequity in your particular practice or something like that. I think, again, the one of the, I'm thinking at it from a feedback perspective. I'm thinking about actionability here. I'm thinking if we're going to provide socioeconomic and additional data like that, I think we'd want to have, for lack of a better approach, an agenda. Like we want to get across a specific lesson or a specific issue about the health equity issues, and trying to, if we have an idea about the message we're trying to get across, then that would help us choose what indicators support that message and what indicators don't. So I think about, again, the sort of actionability. What are we hoping people will do when they receive this feedback? And if the goal is to review my practice in terms of health equity or something like that, then it helps me choose what indicators to provide. Yeah, I mean, I think the goal, as I say, it's a tough question. It's one that I'm not terribly detailed knowledge about. Sorry. Okay. Yeah, sure. But that's it. I think it's more about thinking about the message you want to convey with the health socioeconomic data. Yeah. Yeah, sorry, I'm being long-winded.
No, thank you very much, Jamie. We have a lot of interesting questions, so we hope in the future we have more time to discuss the specific question. So I like to pass the microphone to the last two speakers. The first one is Antonio Giulio De Belvis is one of the most motivated hospitals in the Lazio Region Emergency Project. Giulio De Belvis, please, you can start your speech.
Yes, thank you, Nerina. You are very, very kind. I want to go very, very fast with my presentation. And first of all, I would share with you all, which is the contribution that my unit, I am the head of the critical pathways and outcomes evaluation in Gemelli Hospital. And since 2013, we started with the implementation of pathways, about 45, and around these pathways we decided to build up a monitoring system. And I want to stress your attention on the fact that we have a typical top-down approach in monitoring and the bottom-up in audit and feedback. But first of all, I want to comment with you all this figure from Philip. This is a research that has been published by the BMJ on May 2019. And you can see, by considering the mortality for acute myocardial infarction in the USA, that here in the bottom of this figure, there are no differences in outcomes, only for the presence of protocols and processes, pathways on care. And what is likely to make the difference is on typical managerial and organizational tools. Something like vision, quality glue, or high commitment on data, or high qualification standards, or a very, very strong commitment in the staff, and so on. And this is the reason why I want only to quote what is doing our region, Lazio region, that has developed in the past years a very, very strong evaluation, performance evaluation system. And this is the so-called top-down approach, which really helps all the healthcare organization, let me say, local health units and hospitals, private and public, to start with audit inside, and not only considering this evaluation program as a score, okay, between. And I want to give you an example, just starting from acute myocardial infarction management. This is the monitoring. We have set tens of indicators starting from the protocols of our regional outcome performance evaluation system, and we apply it each 3 months. And as you see, we can monitor how our cardiological units are developing the PCI, and according to a time frame, in this case, we have the limit of 90 minutes that we all know. And when we are below or above the standards, and this is the bottom-up approach, we can select the cases that are not, that do not follow the standard. And so we ask to our pathway coordinators and all the other multidisciplinary teams to start with audit, and then we give a feedback to our CEO, but also to our departments. So just to close, because I realize that we are quite late, but my question is, according to what you have suggested as, if we consider the so-called practice feedback intervention on your article that has been published by the American College of Physicians in 2016, how we can really involve our healthcare professionals and healthcare organization, by considering the Italian NHS context, and you know, according to what you have heard from our representation, that we are not a federal national system, just like in Canada, but we are a typical regional with the devolution in process, in management, and in behaviors as well. Thank you.
Yeah, thanks for that. I mean, I agree. The Canadian system is quite similar, actually, because the individual provinces have, they're in charge of their own healthcare systems, essentially. And so we spend a good bit of time exactly with that challenge of trying to engage the different processes, different provinces in whatever initiative that we're hoping to be broader than one particular province. I mean, from a feedback point of view, it's about identifying their own priorities, essentially. So trying to figure out beforehand what are the things on the front burner right now from the individual provinces or regions or whatever, trying to establish whether you can or have data that might support those existing initiatives. You know, and it's certainly all about, you know, networking and engaging with the right people and all of the sort of standard things that you would imagine any sort of large-scale initiative like that would involve. But I think the benefit of being being the one who has data is that you can go to people first and identify their own priorities, and based on that, you can see what you have and offer it to them, and that's often a really good way to get in the door, sort of thing. You know, basic things like presenting at their meetings, trying to describe how feedback interventions have been effective in other circumstances and might be in this circumstance. Often people are not aware that there is an opportunity for an audit and feedback kind of intervention. They're just not thinking in those terms. And so simply describing the literature on audit and feedback and how it might be brought to bear to address their particular priorities, that's possible, potentially useful. And then on a more individual level, it's about, you know, the sort of standard engaging the end user in your research efforts. I mean, Canada it talks about the CIHR, the main funding agency, talks about integrated KT, integrated knowledge translation, this notion that you need to engage the end user from the beginning in terms of identifying even the research issues, the research program, the research questions. And from a feedback point of view, that's the same thing as identify their priorities and have that design, have that help design what you want to do and what kind of feedback you provide. So those are the, you know, sort of fairly generic guidance, I think, but some that we use a lot when we're trying to engage provinces.
Okay,
thank you very much.
Thank you very much, Jamie. And now the last question about the critical point of barriers and facilitating factors from Fabrizio Veglia from Milan. Lombardy is one of the most damaged regions in Italy from the COVID epidemic. Fabrizio, you can speak. This is the last question for Jamie.
Hello to everybody. Since I'm the last one, I'll try to be rather brief. And I'm Fabrizio Veglia. I'm the biostatistician. I'm the head of biostatistics unit of the Centro Cardiologico Monzino in Milan. And our work package deals with acute coronary syndrome, acute heart failure, and acute valvular disease. So we have no problems with data because we have developed a few of classical indicators like in hospital mortality, mortality at 30 days, and so on. And we have now finally access to the huge database of the Regione Lombardia with data for about 10 million people, and in years from 2006 to 2018. And our original design was to analyze the data from 2006 until 2018, and to identify all the structures that were worse than the average or the median of the region, and address feedback to them. Actually, the feedback package was to be administered by the Regione Lombardia itself. The problem is that with the COVID-19 epidemic, the Regione Lombardia was very hardly struck by the first wave, and it's been struck again by the second wave. So all the healthcare structures were completely upset in Lombardia. They concentrated all the cardiovascular intervention in few hubs, and all the other hospitals were devoted to COVID patients. So in this situation, we ask, it is not possible to provide an audit in the second period after the pandemic, because everything has changed, so we cannot see what is different. So could it make sense to consider the COVID epidemic like an external feedback on the healthcare structures, and to try to get useful information by comparing the data obtained with an audit before COVID and an audit after COVID, when hopefully the situation will be normalized. So
yeah, very, very interesting question. I mean, I think the answer is yes. I mean, certainly presenting feedback on the same entities over time is one of the most sort of common ways of doing it. I think that presenting, if you can sort of continue to present the data over the course of the COVID period, that can help provide just face validity to the data that you're providing. You can, anybody who's going to look at these data can see, oh, there's clearly some huge gap or some massive variation that is associated with COVID during that period. That makes sense to me, and so that'll help me start to unpack what the other feedback, to look at the feedback more carefully. I think it certainly gives people a potential useful picture of how things have changed before and after. And I guess the question for me is, when you provide data over this really disrupted period, what kind of message are you hoping to provide other than COVID really screwed things up? And I think that'll be the challenge, right? Because it'll be, okay, here's the data. Yes, there's this huge gap in the middle where things change dramatically, but we want to draw your attention to, this aspect of the data or that aspect of the data. So yeah, I think for sure it's feasible to do that. I think it's perfectly, there's good examples of how to do that reasonably well. And I think it's more about the sort of messaging surrounding the data and bringing people's attention to the non-COVID related messages you'd like to share.
So, Jamie, thank you very much, Jamie. So now, Jamie, you understand that this meeting was planned to have the honor to meet you and share ideas and thoughts with you, and for you to introduce our research teams in the different part of Italy. So we think this was the main aim of this meeting. Questions are many. More than those we have presented. So we hope in the future, if you agree, if you are pleased to have a new opportunity to discuss with you and show you the progress of our work, if you agree. So these,
yeah, I'd be very, very happy to. And if there's questions that just we couldn't get to or something, and people would like to email me, I'd be happy to do that as well.
Yeah. Thank you very much. So, Marina, if you agree, we are now going to the conclusion of our meeting because the time is this. And I like to remind you that the next 2 EasyNet meetings are scheduled in the spring.